And welcome to the Minnesota Department of Health Stroke Education Series. This month we will be discussing Acute Stroke Ready Hospital Designation 4.0. Before we get started, let's cover a couple housekeeping items. This webinar is part of the MDH Stroke Program Monthly Education Series. Stay tuned to your email for a different educational opportunity each month. This webinar is being recorded, and you can access all previously recorded webinars on our playlist. As usual, your lines have been muted upon entry. Please ask questions by typing them in the chat throughout the presentation, or you can hold them until the end of the presentation as we have saved some time for Q&A with our site review team. If we don't get to all of your questions today, we will address them in the follow-up email. You can also feel free to reach out to the team here at any time. Today's webinar will cover a couple program announcements, followed by the main event, Acute Stroke Ready Hospital Designation. The fourth designation cycle is just around the corner in April 2023. We fondly refer to this upcoming cycle as Designation 4.0. We will cover all things Designation 4.0 today, including what's the same, what's new. We will also take a quick look at common recommendations to expect this time around, as well as how to prepare for overall successful designation. We will save some time after the presentation to engage with our team, our site review team. Couple announcements here. The 2022 Stroke Quality Improvement Awards for hospitals and EMS agencies launched last spring, and the applications are now closed. Kudos to those who applied this year. Thank you. Stay tuned to announcement regarding this year's awardees, and please consider applying next calendar year. It is a fantastic opportunity to share the great work, all your hard work you are doing in your programs. And here's a peek at what's coming up in our monthly webinar series. In December, you will receive a year-end recap of our key educational webinars in case you missed any of them. Evaluations for contact hours will also be reopened. Then in January, we will share an MDH stroke program update to kick off the new year. Now on to our discussion and presentation on Acute Stroke Ready Hospital Designation 4.0. Before we dive in, I want to take a quick pause here and thank you. Thank you for your continued dedication to providing quality stroke care through the Minnesota Stroke System through your designation. Let's start out by reviewing what is the same this round of Acute Stroke Ready Hospital Designation, the 3-year designation timeline. Designation documents are submitted in the Minnesota Stroke Portal on either April 1st or October 1st. Please check your certificate or please contact me if you do not know your designation timeline. Look out for a comprehensive MDH reminder and resources email 3 months prior to your submission deadline. Review that information completely as it has a lot of helpful information. You can also find designation and site visit resources on the resources page of the Stroke Program website. All of the Designation 4.0 resources will be available on the website in the new year, and you will receive an announcement about that. The corresponding designation site visit occurs once within your 3-year designation cycle. This also remains the same in this cycle. The site visit will occur within 6 months of submitting your designation documents. You will receive information and resources beforehand. And also, we will work together on finding a common date that works for you. The very last step in the 3-year designation cycle is to complete a mid-cycle review. This is simply a check-in to see how your program is doing in implementing designation site visit immediate actions and recommendations before starting over and reapplying for designation. What else is the same in Designation 4.0? The designation criteria essentially remains the same. The 9 requirements for Acute Stroke Ready Hospital Designation are the foundation of designation and are based on the National Brain Attack Coalition guidelines published by the American Heart Association. The guidelines state that acute stroke ready hospitals are to provide vital infrastructure, expertise, protocols, and monitoring of care in accordance with nationally recognized guidelines and performance expectations. The goal is to make sure that a patient receives the proper level of care in an expedited and efficient manner. The main focus is ED care in the ability to assess, treat, and transfer patients appropriately. Now let's take a look at the criteria with MDH Health System Supervisor, Nikki Anderson.
Thanks, Michelle. So over the next few slides, we're going to walk through the core designation criteria and highlight evolution of some of these areas and what's on the horizon. A little later, we'll dive deeper into the portal changes and site visit changes as well. So Designation 3.0 focused on improving processes to assess and treat eligible ischemic stroke safely. And as we navigate into 4.0, we want to emphasize the program should be prepared to stabilize and treat all acute stroke types, including intracerebral hemorrhages. As the designation cycle moves forward, we as a program will continuously be updating our materials and strive to provide education to support you in the care of stroke patients. We're also going to continue to monitor and assess safe administration of thrombolysis as well. In 3.0, we focused on developing and tracking stroke education. Please continue to track stroke education provided to nurses and staff that care for stroke patients. In this next cycle, we aim to improve upon established education plans and encourage rotation of relevant clinical topics specific to your stroke program. So for example, at the time of your site visit, your reviewer may recommend that education is provided to all staff that care for acute stroke patients on the code process or safe thrombolysis administration based off their observations throughout the day. Lab testing and brain imaging capabilities remain unchanged. And we've witnessed significant growth in data collection and utilization or performance improvement over this journey and are so proud of the work that you do to improve your programs. Keep up this great work and ensure you are up to date on data submission in the registry, especially at time of redesignation. Continue to work with your primary and comprehensive stroke centers on those transfer agreements and ensure your transfer protocol is up to date and reflects current practice. A designated stroke leadership team remains a crucial component of designation. There has been a lot of work and collaboration at system levels, which is fantastic. And it remains extremely important to have staff on site that are involved in the care of acute stroke patients at your facility. So who are these stroke champions? They definitely need to be included in the management of your program. Now that we've reviewed the criteria, let's just take a deeper dive into what changes you can expect to see within the stroke portal and what's going to be required at the time of submission. So for those of you that have done the application before, we've removed the narrative section from the very beginning of the application and embedded a narrative section into each individual criteria. Guiding questions are listed above the text box for each of those sections, and you can feel free to include more information. One important thing to note, and I'm going to mention this here, and it'll also be in our designation reference guide and resources, but after you enter in your narrative, make sure you click on that update button, which has a red rectangular box around it right now, in order to save that information. So just an example of what this looks like on the screen. This is a screenshot from the new application. This is the stroke code activation log section. Guiding questions that are listed above the text box are describe how the stroke code activation process works at your facility. How do you track stroke activations in real time? How does this document support your PI process? So again, each individual section will include its own narrative. We've also added a whole new tab, which we're pretty excited about, and this is the official documents tab. So this will house programs, site visit reports, immediate action plans, certificates, and mid-cycle reports. Unfortunately, MDH staff are the only ones with editing privileges here, but you as a user will be able to view and download your documents from there. So we'll be the ones that'll upload them there for you. So these 6 criteria outlined here, plus the overarching CEO attestation letter, remain the same. So there's no changes here within the portal except for that narrative section. There are a few criteria, as mentioned, though, that have some adjustments, and we're going to review those over the next 3 slides here, or a few slides. Criteria 1, criteria 2, and criteria 8. In the past, we asked for a template for your stroke code activation log. Then we asked for your actual log that had a list of all your cases. Now we are going back to the template. We just truly feel it's best not to submit those logs that have patient identifiers and protected health information on them. We just want to make note here as well that your stroke code activation log doesn't have to be a paper log. It's a process that can be done electronically. We just want to see, how do you cumulatively track your stroke codes? What does that look like within your electronic system? Use the narrative section too to describe this, what it might look like for your program. And then something else to just note is definitely be prepared to show your site reviewer the actual log used and to talk through how you use it. Again, noting that designation criteria has not changed and the foundation of acute stroke ready designation remains the same. That said, the foundation of designation is to demonstrate diagnosis and acute treatment of ischemic stroke, transient attack, and hemorrhagic stroke patients. So your protocol should coincide with the most recent stroke guidelines, highlight a process that allows for stroke code activation for patients presenting within 24 hours of last known well. This language, again, has fundamentally been the same for multiple cycles, but at this point we are putting an emphasis on the all stroke types, especially hemorrhagic. Approximately 10% of the 795,000 strokes per year in the United States are intracerebral hemorrhages, or ICHs. Per the Minnesota Stroke Registry data, ICHs are responsible for nearly 10% of stroke cases entered. They are the deadliest form of acute stroke, with early mortality ranging between 30 to 40%. We've seen significant growth in the management and care of acute ischemic stroke patients, and so we're putting further emphasis on hemorrhagic strokes at this time. ICH is complex and comes with unique challenges, but timely diagnosis and treatment remain extremely important. In the American Heart Association 2022 Guideline for the Management of Patients with Spontaneous Intracerebral Hemorrhage is a great resource. One of the key takeaways within that resource is that organizations of healthcare systems is increasingly recognized as a key component of optimal stroke care. This 2022 guideline recommends development of regional stroke systems that provide initial intracerebral hemorrhage care and the capacity, when appropriate, for rapid transfer to facilities with neurocritical care and neurosurgical capabilities. We've updated the MDH resource available on the website to mirror changes within the guideline. Please use this as a reference. To note, it's not presently available on the website, but will be in the new year with the rest of our resources. So what are we looking to be submitted into the portal? We want to see your documents that support the management and treatment of ICH at your facility. This may include policies, protocols, algorithms, or order sets. You can also use the narrative section to describe this work. Michelle will talk about this later, but ICH will consistently be included in case reviews at site visits moving forward in 4.0. The next section is data collection and utilization, and we're paring this down a little bit just to really showcase the work that you're doing within your PI efforts. We want you to upload reports that showcase the door-to metrics. This can be what's available in the portal. For those of you that use Get With The Guidelines, you can use the reports there as well. Or it can also be something that your program internally designs. Please limit your PI examples to 5 documents or less within that section. Last designation cycle, everyone received the recommendation to establish a standard for review, at least annually, of all stroke-related documents. We witnessed a lot of inconsistencies across documents that were submitted. So hopefully you've all embedded an annual review into your workflow and are dating your documents along the way as well. Take the time to assess your documents together and ensure they're up to date. Work together with others within your organization, your primary or comprehensive stroke partners, and us here at MDH. The coordinator role is unique, and many of you wear multiple hats, so please reach out early and reach out often. Ask questions and ask for help when needed. Please submit a complete application. It is part of the designation process and really sets the stage for your program. We added the narrative sections to help with this, and please use them to describe your program as best as possible. And from here, I'll hand things back to Michelle.
Thank you, Nikki, for the review of the backbone requirements and submission process for designation. Let's now review the most common recommendations that are assessed through designation. Remember, recommendations are reported at site visit time. The site visit is the culmination of the designation process for your facility. There are 3 levels of recommendations. Immediate actions. These are required recommendations that derive from a concern for patient safety, such as patient care and monitoring that does not follow national acute stroke care guidelines. Immediate actions are to be addressed within a specific timeline as outlined in the site visit report. Recommendations are areas required to be addressed, but by the next designation cycle. This gives your program 3 years to thoughtfully implement those recommendations into your care and processes. Opportunities are not required of designation, yet may help take your program to the next level. Here are the most common recommendations that have been identified through acute stroke ready hospital designations throughout this 3.0 cycle. The safe administration of thrombolytic administration and post-thrombolytic monitoring not occurring consistently according to national guidelines. This most frequently includes missing post-thrombolytic neuroassessments, including the consistency in what neuroassessment is utilized and documented in the record. This may be evidenced through the review of cases, interviews with staff, and review of protocol and documents such as inclusion/exclusion criteria, order sets, etc. This finding is often raised to an immediate action level if there is a trend found through the case review documentation, staff interviews, or review of other documents that don't reflect the guidelines. For designation 4.0, please ensure the safe administration of thrombolytics and post-thrombolytic monitoring, review processes, documents, and monitor cases for compliance. Implement performance improvement as necessary and share these PI initiatives at your site visit. The other most common finding that you saw in your reports this current cycle is establishing, which Nikki just spoke to, a standard for review at least annually of all stroke-related documents, such as your written protocol, corresponding cheat sheets, algorithm, inclusion/exclusion criteria, and your order sets. This recommendation was new, as Nikki said, because we noted variation across documents, language, dates, goal times, or no dates throughout those applications. Having an annual review of documents ensures that your processes meet the best practices of changing stroke guidelines. As you review and update your stroke documents, ensure that you have consistency in language through all of them. Include dates on all of them. And we're reiterating this quite often. It's important to ensure your protocol and documents reflect the most current guidelines from the American Heart Association, American Stroke Association. It's suggested to seek collaboration from your primary and comprehensive stroke center and telestroke partners when reviewing and updating documents. As Nikki detailed earlier, the foundation of an ASRH is to demonstrate diagnosis and acute treatment of all acute stroke types. So the evolution of this is leading us to, you will likely see this common recommendation in your site visits this coming cycle. Hemorrhagic stroke is complex and comes with unique challenges, but timely diagnosis and treatment remain extremely important. As Nikki mentioned, the AHA 2022 guideline recommends development of regional systems that provide initial ICH care and the capacity, when appropriate, for rapid transfer. As we review your acute stroke ready hospital ICH care and processes, you can likely see this common recommendation, and it's designed to further support your program in managing these more complex patients. It's not punitive. We're just really excited for the opportunity to be more consistent and compliant with national guidelines and ensure our acute stroke ready hospitals are providing equitable, comprehensive acute stroke care across the Minnesota stroke system. So how will acute hemorrhagic stroke care be reviewed at site visit time? Your reviewer will review your submitted documents on how you manage these patients. For example, taking a look at what you submitted in the application, your order sets, the narrative, and how you manage patients, any protocols, etc. There will be site review discussion with staff on these processes, just like we've done with thrombolytic care in your facilities. And the case tracer activity will include the review of at least 1 hemorrhagic stroke patient. The Designation 4.0 updated case tracer form will be available on the website in the new year and will showcase what elements the reviewer will look for in the medical record on these specific patients. Now that we've covered 3 of the most common recommendations, let's review how recommendations will be housed in your site visit report. Here's a sneak peek at the new and approved Designation 4.0 site visit report. Designation findings, including immediate actions, recommendations, opportunities, and of course strengths, will be categorized by criteria. The goal is to provide a more clear and concise report and make it more seamless for you from one designation cycle to the next to understand what exactly needs to be addressed and why. We hope we have given you some great programmatic and clinical insight as to what to expect in Designation 4.0. Let's pull this all together and leave you with some tips for a successful acute stroke ready hospital designation experience. Do your homework, please, and prepare in advance for application submission. Review the reference guide and sample documents and other resources. They will all be ready for you in the new year. Pay attention to criteria that need advanced planning. Also, stay tuned to communication from MDH 3 minutes prior to your deadline with all of this information. It is essential to upload your most current stroke program documents that showcase your current stroke code process, documents that reflect most current guidelines, and documents that incorporate any immediate actions and recommendations from the last designation site visit report. So hint, take a peek at your previous site visit report and ensure those are folded into your processes and reflected in your documents. It's also essential to upload a thoughtful and complete application. Remember, what you submit in the portal is what your facility will be evaluated on at the corresponding site visit, which ultimately determines your designation status. The site visit completes the designation process. You will receive further communication from me when it's time to schedule your visit. So to be successful here, please begin preparing for the site visit upon your application submission. Review the site visit agenda, the available PowerPoint templates that are used to present your program, and the other resources on the Minnesota Stroke website. Ensure your acute stroke team members have or are lined up to receive education as you have outlined in your submitted education plan. The site visit activities essentially remain the same in the next round of designation. It is modified in length for the remote process, which many of you are familiar with because of our COVID environment, yet all activities remain the same. There's an opening session for the hospital to present a big picture presentation about the hospital and stroke program. This is followed by a facility tour, including walking through the ambulance bay, registration, indoor triage, ED, radiology, pharmacy, and lab. Staff members are interviewed and their roles in the stroke code process are discussed and verified. Essentially, please walk the reviewer through the path of a stroke patient at your facility. Remember that stroke education files of one provider and one nurse will also be verified. Typically, the staff met during the tour will be chosen for that education review. The case review tracer activity provides a retrospective view of acute stroke care. At least 4 of your most recent stroke cases will be reviewed in the medical record at the site visit. So please prepare this list of cases in advance. From this activity, the reviewer can evaluate and provide feedback on the assessment, medical record documentation, and treatment of stroke patients. After lunch, there's a presentation and discussion of your PI process, including current and future initiatives. Site visits are educational and supportive. Site reviewers provide feedback throughout the visit. And then for the closing session, a verbal report of feedback, including any immediate actions, recommendations, opportunities, and strengths will be shared. This feedback is what will be included in the final designation report that we just took a look at a few slides ago. Finally, here's a snapshot of tips for hosting a successful site visit from the acute stroke ready hospital perspective. These are very valuable tips. Thank you, Karen, for sharing these tips again with your colleagues. Please do take note. Excellent. We are just about right on time here. We have reached our closing Q&A session with our esteemed site review team. I would now like to invite a few of our reviewers to share their video and join us for this last session. Hopefully you have a few questions lined up. But first, I will have them one by one introduce themselves and share their own key tips for success that they'd like to share with you. Well, then it'll open it up to your questions. Tess, take it away.
Good afternoon. How am I coming through to everybody? Hello?
Fantastic, Tess.
You're good, Tess.
Okay. Thank you very much. When you hear dead space like that, it makes you wonder. I'm going to talk a little bit about and emphasize some of the things Michelle and Nikki mentioned about submitting a complete application and a thoughtful application. A key point is that this is the first impression that the reviewer will get of your program. We spend a lot of time preparing. We don't just show up on your doorstep, and we look at a lot of documents, and probably one of the key sets of documents is that application that you send in. So making that as complete as possible is really a helpful thing for us. It's your opportunity to paint that big picture and the day-to-day picture of what happens when a stroke patient comes into your facility. So you can provide the patient perspective, the team perspective of your program, and put that all together to help the reviewer, to help people like me and the others you'll hear from today get a better sense. Certainly, reviewers are sometimes assigned to go back to their previously reviewed hospitals, but I might be the first person in to see your program. So paint a good, thorough picture. I want to emphasize what Michelle said. Look at the references, the reference guide, the Acute Stroke Ready Hospital designated checklist, which will give you the check to make sure that what you're submitting supports the 9 foundational criteria. Think about what has changed in your program over the course of time since your last designation cycle. I've been to sites where I find out that the person is a new reviewer, and that makes a difference just in terms of thinking about the program. I know there's turnover in hospitals and et cetera, et cetera. So tune in on some of those things that have happened internally, but then also what have been your follow-up pieces since your last designation and your last application cycle. One thing I like to do, and especially in light of the fact that we've got a narrative section at the beginning of each aspect of the application, is to use a Word document. I like to just when I was working and doing the Joint Commission applications, I do everything in a Word document for a couple of reasons. One, I can then cut and paste it. It makes it easy to change and update. Two, I could also share it with other leaders within the team. The stroke coordinator is the key person, no doubt about it. But sharing that component and asking for other members of the team, especially the medical director, can get their input, their perspectives, and it kind of brings people together, the teammates together, to get a better understanding of what each person is doing and then their department, how it fits, and how all of it comes together within the stroke program itself. So keep that in mind as a possible side benefit, so to speak, in terms of how the application is put together. Always give voice within your team, and I'm probably speaking to a huge choir here, but bringing it back to the patient is always going to be something that cannot be challenged. If people are having struggles with why you're advancing a change, and you want to include that in the stroke documents that you're revising, bring it back to the patient. And finally, why are the applications again so important to us? We get that opportunity to look at you on paper, but we also are privileged to come into your facility and see firsthand the day-to-day work that you're doing and to look at the matchup between what's on paper and what's happening in the real world. We know sometimes we ask for things like algorithms, policies, procedures. They might have different names within your organization. So make sure you pulled out everything, keeping, of course, within the limits we heard about today, but ensure that you're looking at that. So an ED resource book, that gives the reviewer a great idea of what the ED nurses have to go to. And if we can see a little bit of it ahead of time, rather than when we set foot in your facility, it helps us be ready. It helps us be prepared. And I think the other thing is it helps you get the most out of us as a reviewer. We can then focus on areas that you want to develop, do some problem solving and thinking together so that you can help push your team and we can help push your team to better levels of care, more aggressive goals in your door 2 times, whatever the case may be. But then we can be a more productive reviewer and a more effective reviewer for you once we come in into that partnership opportunity. So I hope that gives you a little bit better sense of why the application does mean so much to us as we're getting ready to see you. Thank you.
Perfect. Thanks, Tess, so much. Donna, I think you had some words of wisdom to share.
Hi. So I just wanted to talk briefly about the different documents that you do submit, in particular those that are algorithms for your process of care or policies or procedures or whatever documents you use that describe your process of caring for stroke patients. And there's a couple of key things you want to think about as you are reviewing those in preparation for submitting your application. One is that you want to ensure they are consistent with the most recent recommendations by American Heart, American Stroke Association. Those guidelines are what all of us use to guide our care. There are sometimes challenges, though, for an acute stroke ready hospital in that those guidelines go beyond what your capabilities are. So do work with your referral sites, or if you're not sure what you're expected to do and what you're not expected to do, you can touch base with MDH about those questions. But an example I'll give you with ischemic stroke is that while we understand very few acute stroke ready hospitals would have the capability to do a thrombectomy, we want you to be recognizing patients who likely have large vessel occlusion or do have large vessel occlusion if you're getting a CT angiogram, and you have processes in place to rapidly refer them to a thrombectomy capable site. So that needs to be built into the documents that we're seeing. We, as was mentioned earlier, we are going to focus a little bit more on hemorrhagic stroke this time around. And obviously, most of those patients, unless they're going to not have any aggressive care, do need to be transferred to a facility with an ICU, with neurosurgical capabilities. So what are you expected to do with those patients? Well, most certainly you're expected to manage blood pressure appropriately. So having some guidance related to that. And you may be looking at reversal of an anticoagulant. Many sites are capable of reversing warfarin. So if you have the treatments available for that, you want to incorporate those into your guidance. There is no expectation that you're going to have the reversal drugs for the newer oral anticoagulants, because a lot of the larger facilities don't even have those, given the expense and some of the challenges in using them. But there is some guidance in the very recently released update to the hemorrhagic stroke management for intracerebral hemorrhage. There's a separate one for subarachnoid hemorrhage that for whatever reason hasn't been updated since 2012. So that one is maybe not the most up to date, but for intracerebral hemorrhage, which is where we would potentially reverse, there's a really nice table of how you can reverse the different agents. And so take a look at that, look at what capabilities you do have, and then incorporate any of those that you would be considering reversal on site. Again, it's not an expectation that you have all of those reversal treatments, but if you do have them, how are you going to use them for patients in your care? The other thing to think about with all of these different documents is, are they consistent with one another? Do they all tell the same story? And one of the challenges with that can be that for those of you that are part of a hospital system, the system sometimes puts out documents that are for everybody to use, and that may or may not actually reflect what your capabilities are. So if you're finding that the document you get from the system isn't quite accurate for what you do, and you have a document that's slightly different, your opportunity to tell us about that is in that narrative statement related to that particular requirement. We certainly understand that your systems will put things out that are meant to cover everybody in the system, and some of your hospitals may be comprehensive stroke centers as opposed to acute stroke ready hospitals. So we're not going to be judgmental about that, but help us know exactly what you are in fact doing at your site with your documents, and make sure they are consistent with one another, so that we don't have one document that says you do this and another document that says you do that. So those are just some of the things that can help you kind of focus in on how you format your documents and think about what you want to submit with your application. And then it also gives us a good reflection of what's actually happening at your site.
Excellent. Thanks, Donna. Angelina, we'll turn it to you.
All right, I get to speak today about case tracer tips for success. I guess in my experience, it feels like sometimes this is actually the most stressful part of the day. So hopefully we'll give you a couple little tips and tricks to help. I think, you know, Michelle and Nikki have already helped by starting to include the site visit case tracer form. So my best advice is to practice. So you're going to need to get a list, just like Michelle spoke to. You want to have a list ready for the reviewer to choose from. So you want to have 4 of your most recent cases, 2 thrombolytic, 1 endovascular thrombectomy, and then new is the hemorrhagic. So have that list ready so that we can choose, but then practice with the most recent case. That will likely be one that's chosen, and use that case tracer form. You don't have to fill it out. You don't need to send it in. The reviewer will be doing that, but it will help you learn how to drive through the chart and step by step what the reviewer is going to be looking for. So feel free to use that as a free run to doing the audits with the reviewer. I would say when I'm doing these, it would be great if you're not the person that abstracts, to have somebody with you that does. That would be really helpful. In some cases, the best person to audit the chart, if you're not the one doing it or abstracting, would be an ER nurse. They're very familiar with admission time, where to get the weights, where to get the glucose. But you want to be really familiar with the results as well. So knowing how to get those CT times and the CT read times. What my experience has been is that after you go through a couple charts, you start to kind of get a rhythm and a nice flow. But if you don't know how to abstract, it can be very, very challenging and know the charts. So I definitely think you should practice. Or if you are challenged in that area, have somebody who knows how to navigate through the chart. If the review process is going, and let's say, for example, you know they're going to ask for the consent and it's right there, speak up. This is just a back and forth conversation. Say, you know, before I go and show you that glucose, right here is the consent. The neurologist says it in their note right here. So those are helpful for the reviewer and for you. We can just get it crossed off the list, and then we don't have to keep going back and forth. You know, each chart is a little bit different in how they're set up. So we rely on you a little bit too. I think those are the main things. Again, make sure you have the most recent cases. Those are the ones that we're going to review. At least 2 thrombolytic, 1 endovascular, and then new is the hemorrhagic.
That's super helpful. Thank you, Angelina.
Yeah. The one thing I just had one other thought. The biggest challenge is people know how to find the vitals, but make sure you know where the neuros are as well, and how often and how thorough the expectation it is for the nurse to have those filled out. So vitals, people seem to have pretty hardwired. Neuros sometimes can be challenging, and they're found in several different areas. Definitely know how to find the neuros and how often it's required for them to be completed in your acute stroke ready, in your ER.
Perfect. Thank you so much. Fantastic. And I think we have Liz Holt has joined us as well, who has some.
Hi, good afternoon. Yeah, so I was just going to chat a little bit about open communication with MDH and your reviewer leading up to your site visit. So just make sure Michelle does a great job with sending emails out prior to the visit. So just make sure that you look through that email and read it completely. Look at all of the attachments. They're there to help you with some of the templates, your agenda, the tracer activity, and what to really prep leading up to your designation site visit. So if you have any questions, just know that we're here to help you. You can reach out to MDH and or your reviewer. They're happy to set up a time to chat with you before your visit. Usually your reviewer will reach out to you about a week prior to your designation visit. So let them know, especially if you're having a remote visit, let them know if you have any questions regarding the technology or who to all invite. This is really just, we want to help prepare you for your visit. This is something that we look at to help grow your program. So just know that we're here to be a resource for you and to answer any questions that you have. We know it's a lot of information to gather and prepare for. So even if you're running a little bit late with preparing your PowerPoints or gathering documents, just let your reviewer and MDH know, so that way they know that documents are coming or that you are preparing. Sometimes if you don't hear anything, you kind of wonder what's going on. And again, we're really just here to help you prepare. So make sure that you reach out to MDH. There's a lot of great resources on the website as well. So look at those resources and what's requirement for your site designation visit, and use those documents as well. So just make sure that you're not a stranger. If you have any questions, we don't want you to kind of be scared or on an island as you prepare for this. So we're happy to assist with any questions. So again, if it comes down to what documents you need to gather, who to invite, how it works for a remote site visit, just don't hesitate to reach out.
Super well said. Thank you. Thanks so much, team, for sharing your wisdom. Was there anybody else on the line, Carol or others, that had wanted to jump in here last? I know there was some time conflict with the rest of our team. We'll give them some time to jump in if they want. Otherwise, the floor is now yours. The stroke coordinator's on the line. We have as much time here as you need, well, until 1, to answer any questions you might have. So feel free to pop them in the chat or press *6 to unmute your lines. You've got us all here. It's a great time to ask questions. We don't have any questions in the chat. Thanks, Catherine. Trying to have this uncomfortable silence, but it looks like we might have covered.
This is Angela. When some people on my teams weren't able to attend today, when will this, either the slides or will there be an audio or video shared that we can share this
Yeah.
presentation?
Yes, this will be recorded and posted on our YouTube page, Angie. So we will send a notification of that. I would envision by the end of next week. So along with that,
Great.
yeah, so as soon as we have that available and on our website, we'll send that out to the full list serve, including the slide deck, and a couple other reminders or resources that we have at that time. So rest assured that will get out to folks. Thank you for the
I
question.
thought this was a great summary. Thank you.
Super. Yep. Thank you.
We do have one question. Maria would like to know where the list of when the our next application is due.
Hi, Maria. Yeah, so you know it's on a rotating timeline when your application is due. It's either April 1st or October 1st, depending on when your cycle first started. It's every 3 years. So the best thing to do is to check out your documentation, look at your certificate, or just send me a quick email and we can look at that together just to make sure you're completely squared away so you know exactly when to submit. And then just a quick little reminder about that. I do send a pretty comprehensive reminder and resources email that goes out 3 months prior to each application deadline. So you have that time. A little more preparation than that is probably useful. So just check out that timeline or contact me. I'll help you.
Hi, this is Mary Zachman calling. From an abstractor perspective, I noticed that you've added in the history at the end of the portal, if the patient has emerging or history, is it of COVID or SARS? And I'm wondering, are you looking particularly if they're considered to be suspected of having COVID at the time, or if they've had a history of one of these?
That's a fantastic question, which I'll have to follow up on because I'll have to check our abstraction guidance. And I know Allie, who is our quality improvement coordinator, I saw a notice that she hopped offline too. So she's typically the person that answers those questions. So we'll
Yeah,
follow up
okay.
directly.
Yeah, every time I get that question, I'm a little gray on it and I just go, okay. So yeah, I was thinking about reaching out to Allie, but since I was here, I thought I would just ask. So thank
Hey,
you.
you had the floor and we were all here for that. Unfortunately, I can't answer it on the spot. I have to check
Okay.
our resources too.
All right, thank you.
You bet. Any other questions from folks on the line? Great.
Okay. Well, thanks, folks. I think this was hopefully as useful it was for you as it was for us to kind of regroup all together and get excited and prepared for 4.0. Thank you for joining us, and as always, for your continued partnership in the Minnesota Stroke System. If you had any last questions or comments, please feel free to jot those in the chat. We can take those in and get back to you about that. And then otherwise, lastly here, the link to the survey was placed in the chat. Remember to click on the chat bubble in order to view the chat box. Upon the completion of the evaluation, this time around, you will receive 1 full contact hour. Please stay tuned to your email for, as I mentioned, I'll be sending out the recording of this and relevant resources. And in the coming months, then stay tuned for the upcoming monthly educational opportunities. We wish you well through now in the holidays, and take care.
Thank you so much.